I'm Diana Fishbein. My day job is at Penn State University, and I also direct the National Prevention Science Coalition to Improve Lives, which is a national organization to take what we have amassed in the prevention sciences and translate it for the implementation scaling of evidence-based practices, as well as the refinement or reform of policies so that they can be more consistent with what we know from the science. With respect to the opioid crisis, there's a lot of different parts of the elephant that you can get a hold of to, speak to different aspects of the crisis, having to do with pharma regulations and more of a treatment viewpoint. There's just different ways that you can approach this problem. But because I work all my work is related to prevention science. So I'm a neuroscientist actually, and I study the effects of the environment on brain development in childhood and adolescence. But everything that I do, I think what we can do from a preventative standpoint will have the greatest impact over time, especially intergenerationally. So I also work on the effects of intervention on brain development to see ways in which it can accelerate development and functioning in children in multiple domains. So I'm kind of going to take that standpoint, and there'll probably be other questions that I can speak to just from book knowledge, if you will, but I'm going to give you a perspective that I'm most familiar with and comfortable with. So to get started, this is just the range of topics that I'm going to cover in the next 20-25 minutes. I'm going to start with myths and facts because there are many myths about the opioid crisis, and some of these myths have actually led to policies that can be detrimental over time. So I want to just touch on that and then talk about pathways to addiction so that we understand that people just don't suddenly become addicted to drugs out of nowhere, that there's a pathway where we can intervene at multiple points in the trajectory towards addiction in order to divert that trajectory and change outcomes for these individuals. I'm going to talk a little bit about evidence-based programs. I'm not going to talk about specific programs, but just that there is a body of programs that have been developed that have been shown to be effective in diverting these pathways. I'm going to mention the role of law enforcement. I've worked a lot with law enforcement over the years, starting very early in my career, and I feel that they are underutilized and could be a tremendous resource for us in this battle. I also want to mention the intergenerational effects on the children who are being raised by individuals who are addicts, and ways in which we also need to attend to this and not put it off. Because it will create an entirely new generation of addicts if we're not paying attention. I'm also going to deal with the difference between dependence and addiction. They're worlds apart, and understanding the difference between the two, you will see has direct policy implications. And then I'm just going to mention medical marijuana. The body of evidence is still very premature to embed this in policy, but it's just something that we're looking ahead in terms of the research and ways in which it might help us to find replacements for pain. So with that, I will start with myths and facts. The first myth is that most prescription opioid users turn to heroin or fentanyl or something else. And it needs to be understood that the overwhelming majority of legitimate opioid users, and I mean people who are using it for pain, never progress in their use. So I'm going to talk about that in more detail. Relatedly, another myth is that this legitimate opioid use for pain invariably places patients on a fast track to addiction. when I get to the topic about how addiction and dependence differ, you'll understand why this isn't true, and that we need to turn our attention to individuals that are not necessarily taking pain medication legitimately, but those that are not. Related to this myth, the idea or the misconception is that many people turn to illicit prescriptions, and then that leads to street drugs. And yes, this is a new pathway. And when I say new, I mean it's certainly been in effect for many decades. But the rate of this and the facilitation of this pathway, if you will, has just really gone viral. There are just thousands of more individuals that are going down this pathway. But it is still very important to recognize that most legitimate pain patients do not go this route. And so we need to understand why. So the fact is that only a small portion of those that become dependent on legitimately prescribed opioids become addicted, and even fewer turn to illicit opioids. Another fact that we'll discuss is that withholding opioids for legitimate purposes will increase illegitimate use, and we're already seeing that happening. That has already been happening. And so some of our policies are actually leading or encouraging people to look for their medication elsewhere, because the medications that they've been using are being cut off very abruptly and without adjunctive treatment, without replacement medication. There are cases where they're basically being told to stop using the drugs. Their prescription will be cut off within a few weeks in response to this crisis. And this is not what most legitimate pain patients need. They need doctor-monitored prescriptions that where there's accountability, and there's monitoring for side effects, and there's monitoring for to ensure that individuals do not start to use indiscriminately. So we will talk about that. Another myth that's very important in this whole conception, and that speaks to what we know from the prevention sciences, is that everybody is equally vulnerable. So that if you take an opioid, that invariably, again, you will become addicted and you'll start using eventually street drugs. Everybody is not equally vulnerable. And the fact is that some individuals are more vulnerable to addiction than others. And there's 30 years of NIH funding that has led to research that has disproven this notion time and time again, that everybody is equally vulnerable to addiction. There are all sorts of risk factors. I'm not going to talk about genetics in this talk, but I am going to talk about other risk factors that can increase the propensity to addiction, that we can manipulate, that we can control, that are preventable, that are malleable. And then finally, another myth is that marijuana is a gateway. Marijuana is not always a gateway. Many people just use marijuana if they are already using, and don't use anything else and prefer that drug. And there are people that use it well into adulthood and never use anything else. So the notion that marijuana is a gateway, meaning that it's inevitable that they will progress to harder drugs, so to speak, is incorrect. And in fact, any drug can be a gateway. So back in the Vietnam era, people used heroin in Vietnam. It was readily available. It's grown there. It's grown next door. And that was their coping for the atrocities and the difficulties and the stress and the adversity of being in Vietnam. So there were thousands of our troops who used heroin. So you would think they would all come back and be heroin addicts. But the overwhelming majority of our Vietnam vets who came back after having used heroin regularly in Vietnam quit. They quit. And there's a subgroup that continued to use and continued to have serious problems. But we understand now better why so many were able to quit and why that subgroup was unable to. And it has provided a framework for us to understand that there is a differential susceptibility to addiction, and that in many cases, the environment that an individual is in can perpetrate that susceptibility. And so the environment changed when these individuals came back. And basically there was no need for most, that they had the support from their families and so forth, and that they were not inclined and they did not have mental health issues and so on and so forth. So that's just been a tremendous lesson that we've taken with us to further try to understand why individuals are differentially susceptible. So we can focus. We want to be able to focus. So what are some of the policy shifts that are implicated by this information? In order to exert a measurable impact on this crisis, we must first consider the underlying reasons for the differences between people who succumb to addiction and people who don't. So again, there are people who take pain medication even, for years and don't become addicted. And there are others who, even in adolescence, experiment but don't escalate and don't go on to addiction. We need to understand what these differences are. We also want to enforce a demand reduction approach. So not just supply, in this particular instance with opioids being so readily available as they have been in the past and unregulated on multiple levels. A supply reduction approach is absolutely necessary. But let's not forget about where the demand is coming from. So we want to focus on what the underlying problems are that lead people to use and eventually abuse and become addicted. It's not just about the drug itself. Interestingly, we say, oh, this is the decade of opioids. Well, we've had other decades of other drugs, methamphetamine, cocaine. We've had other decades that have been, where we've seen a tremendous proliferation in drug use of one drug or another, ecstasy, designer drugs. The problem here is that most of these other drugs do not cause the rate of overdose that opioids do. And so that's what has made this decade so much more concerning. But again, if we focus only on the drug, then we're losing the focus on the individual susceptibility, and we're losing the focus on environmental and social conditions that we can intervene in and manipulate to increase resiliency and divert people away from drug use. And we need to start early in life. There's no question about it. We need to start early in life. The earlier the better. So we need not to just focus on individuals who are already addicted. We need to focus on the younger generation from the beginning. And we need to develop new policies to reduce illicit use of prescription medications, but consider the legitimate needs of our patients. And these patients are our vets. There are vets, there are athletes, there are injury victims, all across the spectrum. That's who these pain patients are. And so we need to focus on what they do need legitimately to control their pain, and identify individuals that are using illicitly when they don't need to control their pain, or at least not anymore. These strategies will determine how we can direct our precious resources. Otherwise, we're just sort of, throwing it out there, and we're not thinking about where the needs are that are going to have the biggest impact with respect to our policies. Okay? These are some of the vulnerability factors. This isn't new. There's nothing new about this. The problem is that we haven't been paying attention. And we've known these vulnerability factors for 30 years. They are in multiple dimensions of life, We know that there are individual factors that increase propensity to addiction, mental health problems, anxiety, depression, and so forth, conduct problems. So to be honest, the one very consistent finding in the field of drug abuse research is that the most impactful factor, the most predictive factor in terms of what kids are more likely to abuse drugs than others, and the factor that continues to be most important is aggression, aggressive behavior, conduct disorder, externalizing behaviors, off-task behavior in school and at home. So, and eventual delinquency. But as you know, delinquency and drug use go hand in hand. But that's part of the linkage. So we need to pay attention to conduct problems early in life and address them. Also, academic failure. So individuals are having problems. There could be all kinds of reasons. There could be trauma at home and the reason why they're not doing well in school. Or there could be learning disabilities, ADHD and so forth, also known to be individual propensity factors. So these are individual level factors that we have tools to address these conditions. We also want to look at the environment. Poverty, number one. I mean, poverty is, it comes with trauma, it comes with deprivation, it comes with discrimination and inequality, it comes with so many different things. So poverty really spans, I don't know if you can see my cursor on the screen, but poverty spans all of these other dimensions in terms of risk. And then environmental toxins, lead and so forth, have a direct connection to the propensity to abuse. Lack of opportunity is another, and homelessness. Some of these I put in here because this list is so long, but I put those in that I just think are the most prominent and most self-explanatory in terms of their linkages. Stress affects propensity to drug abuse, and that includes from poverty and other sources, but stress and adversity. In fact, stress acts on systems in the brain that underlie mental health problems, that underlie drug liking. So let's take rats, if you will. If you stress rats, they will self-administer opiates at unprecedented rates. So stress actually has an effect on the brain that neurobiologically increases propensity to use drugs. It increases drug liking. You can use a drug and not care for it, not care for marijuana, not care for any of these other drugs, not care for opioids. Personally, opioids make me sick to my stomach. So why am I different? Why do I hate it? And other people just find solace in opioids. Stress has a lot to do with it. And so some people will self-medicate their stress with alcohol or exercise. I mean, there's all sorts of ways to self-medicate stress that are more productive. But the effect of stress on the brain has a direct impact on neurotransmitters that are involved with drug liking. So dealing with child maltreatment is preventable, and it's a huge factor in susceptibility. Social isolation, also a big factor. And then, as I said before, and I mentioned it having to do with poverty, racism, discrimination, and inequality are very big in this issue. And then also personal experiences, exposures, lack of parental involvement and social supports, negative peer influences, and poorly equipped school systems. School systems that are better equipped will oftentimes recognize the issues that children are having and provide intervention. But in our poor schools, we see the least amount of resources being dedicated because they can hardly afford books. So this is another area where we can intervene very effectively to scaffold the environment for children. And now, pain and prescription drug use is a susceptibility factor. So just being in pain and having to use prescription drugs and not having these other things in place So it's more often than not that people who are using prescription drugs, who escalate to illicit drugs, have mental health comorbidity and other issues, stress, discord in their family life, etc. It doesn't occur in a vacuum. This is what I really want to get across in this talk, is that people don't just all of a sudden become addicts. There are pathways that individuals follow before they become addicts. And here is just a delineation of some really rudimentary skills that children need to acquire throughout their lives in order to have the self-regulation that it takes to veer away from substances. So at any given age, there's, the intellectual ability, there's the development of language is critical, at early ages. And then as you get older, the development of cognitive, emotional, and behavioral self-regulation is very critical, and social competency skills. So these are just, a smattering of skills that children need to learn that are protective. They have been shown in literally thousands and thousands of studies to be protective against substance abuse later in life. So if we can ensure that our children reach these developmental milestones, then we will not be dealing with the rate that we see today. I have brought up adolescence as a particularly important time to intervene. Some people say to me, well, isn't it too late after, once they're adolescents and they're already entrenched in whatever it is that they're doing, the risky decision making and so forth? No. In fact, when I was growing up in the field, in the early part of my career, I was told, don't study adolescents because they're so unstable. You can't control anything in your experiments. They've got hormones, their development is off, and they're all over the map. There's just too much variability in adolescence. But what I have since found in the past 20, 25 years is that is one of the most dynamic times of development is adolescence. And it's a great time to intervene if we haven't intervened before, because sometimes the behaviors don't manifest until adolescence. And so we need to think about what it is that they need to have in adolescence that will help them make better decisions, control their impulses, cope with their environment and with stresses, being sensitive to the needs of others, and so having stable relationships. It's very important that we ensure that our kids, at least by the time they're adolescents, have developed these skills. And there's a whole movement, it's a national movement to increase socio-emotional learning in the schools, in our schools, so that children can develop these skills and have the wherewithal to be able to go a different route when substances are offered. It's not just say no. It's not about just say no. It's about scaffolding children with the skills that they need. So, and this is what the adolescent brain is like. This is why, there's more risky decision making in adolescence than at any other time in life. If we haven't hit them up early in childhood, we got to get them by adolescence, because the brain is developing in a strange way in adolescence, where you have more development in the emotional centers of the brain than you do in the cognitive control centers. So we have this imbalance. So although kids have cognitive, adolescents have cognitive abilities, their emotions often overwhelm them. So even normatively, kids and adolescents are more risky than at any other time in life. But when you have non-normative development and kids are experiencing stress, maltreatment, divorce in the home, poverty, whatever it is, this imbalance can be even more extreme, and they're more likely to start using drugs. And so again, getting them early. We know that drug abuse is a developmental problem. As you can see in this slide, this is when the onset occurs. And the age of 15 and 16, that's when they peak out in terms of onset. Most of them will stop using, most of them. But we have to be concerned with those that are continuing to use. So this slide just shows how onset of drug use is unusual later in life. most of the onset is by the age of 15, 16. Okay, and we have interventions for that age group. So the significance of this information for the prevention of opioid use, and in fact all drug use, is that we need to look at the impacts of social environmental risk factors, and what the consequences of those risk factors are will depend on these personal characteristics that I discussed, mental health, learning issues, and so forth. And they develop and evolve over time, so they're not static. We need to be aware of how they're developing and varying over time. So we need to look at the developmental period of when they're exposed to risk factors. And these factors help us to determine what kinds of programs and policies are effective at any given time across development. This is a slide from the Institute of Medicine report on prevention a few years ago. These are not specific programs, and I can give you that information. I'm happy to make myself available to you. But what this shows is the kinds of interventions that are available and that have been well studied, so that we have an evidence base for an expectation that they will work, okay? And we see early in life, there are pregnancy prevention programs, prenatal care is very important, home visitation, I'm sure you've heard of, nurse-family partnerships and so forth. High-quality daycare is very important to prevent later problems. And then once you get into childhood, there are different kinds of interventions that might involve parents, that might involve family. And I think it's very important to be comprehensive in children's lives. And so you see these are, and I'm happy for you to have these slides, but you can see the different kinds of programs: parent skills training, social and behavioral skills, classroom-based curricula to prevent substance abuse, aggressive behavior and risky sex. Later, we're interested in depression. We want to prevent schizophrenia, which is very much associated with drug abuse. And then at the bottom, you see that there are more broad interventions that bring in the family and look at ways to help children cope with what's happening on a family level. And then we have community-based interventions that are extremely important to scaffold on that level. And then how can we build policy that will actually help us to create pipelines from schools to primary care to local agencies, so that we're sure that children are being identified in all dimensions of their lives to ensure that they receive the care that they need. So if some problem is coming up in school, it doesn't go straight to juvenile justice, but maybe it goes to primary care. Maybe it goes to one of these prevention programs in the community. So the implications for early intervention are that, problems underlying drug abuse all involve poor self-regulation, no matter what the issues are. And they are preventable if they're appropriately addressed. Evidence-based programs, as you can see, these programs are actually effective because they are mapped to the underlying problems that I talked about earlier. That's how they work, by addressing the underlying generators of how the individual is progressing. Appropriately targeted interventions may be especially impactful for disadvantaged children who experience a lot of social adversity. And the final principle here is that a comprehensive evidence-based set of solutions to prevent drug abuse operates to enhance multiple domains of functioning. So just looking at the individual isn't going to do it. You have to look at the individual in their context, in their schools, in their communities, in their schools. Okay, so we have to look at them in different contexts and ensure that we're hitting it in all aspects. And I just want to say one thing real quick, and I hope I'm okay with time. But I just wanted to say that while I tout the use of evidence-based interventions, I also think that we need to promote policies that that educate the public about the daily practices and the daily interactions that we have with our children. All child serving all child-serving organizations, including parents and daycare and schools and child welfare agencies, that if we understand the principles by which children grow in a way that's the most healthy, that our daily interactions, the principles that the basic principles that underlie these interventions, that we are practicing them at all times when we interact with our children. So it's not just about how much money do we need to get all these interventions into place. And believe me, they're a lot less expensive than what we're dealing with now without doing them. A lot less expensive. But if we were to interact in a healthy way with our children at all times, then we could certainly quell the drug abuse that we see later in life. So I'm almost done, just to speed it up a little bit in case there are questions, right? Is that I would also like to advocate for some new tools in the toolbox for law enforcement, that we have taken a pretty traditional punitive approach to opioid addiction, and what we see is that it just results in a revolving door between jail and the streets. Sorry, there goes my phone. And instead, we're in addition to, I don't think that we should take a punitive approach, but certainly, there's a time at which, we need to react with drug trafficking organizations and that sort of thing. But if we could think about law enforcement as being the first responders, like, let's remember what public safety is about. Public safety is of interest to the police, and it's of interest to the public, to the communities that they serve. But we seem to have forgotten what public safety is about. And if we could develop strategies that would connect law enforcement enable law enforcement to connect people with addiction problems to healthcare and treatment as a referral system, right? Then that's something that they could readily do, and not just have arrest as their only tool, but rather to think about how law enforcement can be a referral to the treatment that they need, and perhaps, help them, do something, get into a more effective modality, rather than just being arrested and then ending up back on the street without any attention to the underlying problems. I would suggest the development of training modules that would help police understand the very nature of drug addiction, its causes, and the people who are afflicted by it, because there are many misconceptions, and having that knowledge increases their power to do something effective. And then training and options for addressing the needs of children that are found on the scene. In many states, I don't know what happens in Alabama, but here, the children are ferreted out to other homes without any vetting. So they may go to a neighbor, they may go to a relative, they may go to a friend. There's no vetting. So they find a home is found, and that's where they go. Many end up certainly also in foster care. But the problem is that they're not getting the trauma-informed care that they need. These children have experienced trauma. They live in a home with individuals whose first priority is, where are they going to get their next fix, if we're talking heroin and things like that. So we need to pay attention to the needs of these children, and I think that law enforcement could also be a very effective referral body for these children. So the police are frustrated, and they're not given a lot of these tools to give them different options about how to respond. And this, I think, would increase their efficacy in dealing with the problem. And then the children of addicts. This is something that's very dear to my heart. I'm developing a protocol for Philadelphia with some of their communities that are very impacted by the opioid crisis, to make sure that these children get the attention that they need. So we focus so much on the addicts, getting them Narcan while they're overdosing, or even getting them into treatment. but we're not really focusing on the children to the extent that we should, in my view and the view of many others who are in this field. And we can assure all of you and others that if we don't look at the impact of this opioid crisis on their safety and their mental and physical health and the school readiness of their children, that it will exceed the impact of what we see today in terms of morbidity and mortality, because it will be our next generation, and it will be a much more difficult generation to deal with. So these consequences, like, they might be long term, but we're going to have to deal with them. And to date, they really have not received a lot of attention. So what we need is a cross-systems agenda to reduce their exposure to dangerous drugs and to deal with the effects of the parents' addiction on their ability to take care of their children in many respects, and what that means for their children. So we need systematic, effective, evidence-based, trauma-informed, I know it's a mouthful, trauma-informed clinical and community-based interventions. Otherwise, again, we'll deal with another generation, and we'll deal with the criminal justice involvement of the children today that are growing up under these conditions, their criminal justice involvement that will make it more and more difficult to treat a very entrenched problem at that point. One more very important point, and that is what I said earlier about there is a big difference between dependence and addiction. And I wish I could see you so we could have more of an interaction. It's not so much fun this way. But dependence is a physiological and treatable outcome of regular use, including when prescribed for chronic pain. There are many pain patients who are dependent, many thousands of pain patients that have a dependency. They need it for their pain. They need it for their cancer. They need it for various medical purposes. But they never escalate. They never become addicted. Addiction is the compulsive aspect of drug-seeking behavior. And what they're seeking is an altered state of body and mind. It's not for medical purposes. So addiction is the psychological compulsion. Gotta have it. That's my first line of business when I wake up in the morning. I gotta make sure that I have enough drug to get me through the day. It's different from dependence. And the issue here is that there's nothing inherently unhealthy about a sick patient or a patient in pain being dependent on an opioid. Seriously. The problem is addiction, and that's where we need to focus. That's where we need to focus. So the policy implications of the indiscriminate tapering of opioids, these prescription drug monitoring programs, the problem with this is it will increase risk for addiction, because pain patients and others will have to start seeking alternative means of getting their drug. And it will lead them to this. It is leading to the street. I mean, there's documentation that this is already happening, and that we have actually, through our policies, worsened this already horrendous problem. It is leading them to the street. It is also leading to suicide and other violent acts to get their drugs. I'll tell you a quick story. A friend of a friend, I know, like, it's a little indirect, but she's one of my best friends, and her friend had raised her disabled child for 28 years, having to lift him. He was horrendously disabled, to lift him every day of her life. And now, well, late in her 50s, had so much pain from structural issues due to lifting her son. She was dependent on opioids for pain relief. She was just like me and you. She wasn't looking for drugs on the street. She was relying on doctors, accountable, responsible doctors, monitoring her use and ensuring that she had just enough to make it through the day. And when he told her that she had 3 weeks to wean This is what's happening all over the country. 3 weeks to wean, no alternative medication, no adjunctive treatment. After 2 weeks, she committed suicide. So, sorry, it gets me, because this is what is happening when we start to remove these drugs from people just like you and me who need it for pain. It's also worsening comorbidity, because people become more depressed and very anxious. So all kinds of mental health issues come up when they're not getting legitimate pain relief. And it also leads to, as they're seeking drugs on the street, to inappropriate medical monitoring. They're not able to get the medical monitoring that they need, because now they're seeking it illegitimately, even though all they need it for is pain relief. So that is, I think, we're going to be doing a congressional briefing on this later in the year. We have 2 others we have to do first, but I think that we need to consider what the target is. And they're not our athletes, they're not our vets, they're not injury patients, we need to focus on people who have addiction. And I also wanted to mention this potential role for marijuana. This is another topic that has been getting increased attention. Actually, it was on 60 Minutes a couple weeks ago. So it's the cannabidiol is not THC. It doesn't get you high. It's not addictive. And it is starting, the literature on this is a little early to know for sure, but it does seem to reduce craving. And so it reduces the likelihood of relapse. It can treat pain, and some believe and are using it to assist with withdrawal from opioids. And it can treat mental health issues and comorbidity that occurs with opioid use disorder. And it has medical benefits, as we know. We already know that it has some medical benefits. So there's even some indication that it might have anti-tumor effects. I want to be sure that if we're considering this, that we're doing it responsibly and are attending to the literature, which is still in development. But I also want to just give my little qualification that I think it has been harmful for us to roll out policies on legalizing or decriminalizing marijuana without corresponding public education, because in states that are legalizing, we're seeing jumps in the use by adolescents, and marijuana has very well known hazards. There are very specific issues with using chronic or heavy marijuana in adolescents. And unless we inform the public of what these issues are, we're going to have problems from that as well. So I just think the public we need informed consent, right? We need the public to be educated about what all the dangers are, and not just, let it out there indiscriminately. So I'm going to stop here, because I think that I've gotten most of the points across. We can do prevention at all ages was, some of the last things that I just wanted to say, and that it's never too late. Throughout the lifespan, there's always potential to intervene effectively. We're plastic. Our brains are plastic, so there's a lot that we can do to improve development for individuals that have these psychiatric problems.